And I want to thank the team so much for inviting me. Who thought the weather in Poland would be so much better than the weather in Canada? But I am grateful. Thank you. And thank you to Dr. Malshine and the whole team and our wonderful hosts. So I actually changed my topic because I just thought talking about chemotherapy on a Saturday morning was not what you wanted to do. So I've actually changed it to talk a bit about the revolution in targeted therapy that we're starting to see, and I hope it complements the presentation that Dr. Kelly gave. And I think it's widely accepted that what we see in earlier stages of lung cancer is similar in terms of the molecular profiling to what we see in late stages of disease. And even in countries like Poland, where there's a high frequency of tobacco-related cancer, at least 40% of patients can have driver alterations. And so I think this really underscores the need for molecular testing and trials of targeted therapy. Of course, moving into the very early stages, things are a little different. I'm just going to present data from 2 studies. This is a nice Italian series where they looked at patients with ground glass lesions all the way to subsolid lesions, and these were all lung adenocarcinoma, so at least minimally invasive, I think, in the pathology. And you can see that there's a very high frequency of alterations, as you can see here, many of them actionable in dark blue. In particular, in very early stage lesions, a high frequency of EGFR mutations, and as things become more solid and more invasive, more KRAS mutations with a faster doubling time, and activation of multiple pathways. But you can even find fusions and more complex alterations that are targetable, highlighting a future where NGS probably will play an important and standard role in this disease. Flipping it around from a less radiographic perspective to a more pathologic perspective, these are very nice data from colleagues in Japan, where again they showed the same idea that whether it's non-invasive or AIS, all the way to minimally invasive and advanced disease, you do see a very high incidence of EGFR mutant lung cancer, and we saw this also in the Italian trial, so it's not Asian only, but also other alterations. And as disease becomes more invasive, you really see that destruction of normal chromosomes. You start to see loss of tumor suppression, more methylation changes, and things like SMARCA2 and 4 loss and changes in the tumor immune microenvironment. So again, profiling even of value in earlier stage disease, and this study looked at whole genome sequencing. So who cares about NGS and stage 1 GGOs? I think it's to do with the extraordinary change that we've seen in advanced disease. Now in my clinic, I teach our residents about 16 different approaches to treatment in our patients with advanced lung disease. And wouldn't it be great to see that evolve to early stage? And we're certainly on our way, as Karen highlighted, chemoimmunotherapy, so important now, but also adjuvant EGFR targeted therapies from stage 1B higher, ALK targeted therapy in stage 2 and stage 3 with some emerging data in stage 1B, and of course in our patients with stage 3 unresectable disease, a growing role for consolidative targeted therapies. And so when we published the recent ESMO guidelines, and this is consistent with other guidelines, we've agreed that upfront genotyping is essential. If your tumor is 3 centimeters or more, you do at the very least need EGFR and ideally ALK testing. And I think over the next few years, we'll have enough data to recommend NGS. And of course, then it's a matter of bringing it to stage 1A. So it really started with this trial where we saw marked improvement in patients with stage 1B, so 3 centimeters or larger, or with high-grade features if patients had stage 1B disease. We saw very nice disease-free survival improvement with adjuvant EGFR inhibitors in patients with classic mutations. And to our surprise, this translated in the bottom left here to overall survival improvement. So we probably are curing some people with adjuvant TKI, but even that delay of recurrence is translating to better outcome and better survival for patients, which I think is something we were not expecting to see and is very promising. After 3 years, we stop the treatment. You start to see that these curves change. Does that mean everyone should be on this drug forever? And I'm going to show you some more data that suggests that we need to do a better job of figuring out how much treatment people need. For this group, what about in our patients with stage 1B disease who mostly did not get adjuvant chemotherapy? Well, there does still seem to be an impact with adjuvant EGFR TKI in this population, definitely a disease-free survival impact with a similar hazard, and these survival data are emerging, as well as studies looking at smaller tumors and earlier stage disease. They did publish some very nice ctDNA data from this population. This was using a personalized panel using whole exome sequencing, the RADAR panel. And what they found that was very interesting was that in the placebo group, about a third of patients, sorry, let me make this go over here. About a third of patients never had ctDNA detected and didn't have relapse. Does that mean they don't need treatment? We haven't looked at that question, but I think it's important. But also, in about a quarter of patients that were on targeted therapy, after we stopped, a number of them had recurrence either in plasma or on scans. And so is this a group where we could re-intervene? And so there's a study going on in China looking at whether we can use CT-directed adjuvant therapy. Now, I showed these data from China. This is a third-generation TKI, very much like osimertinib, but really for the data on the right. The data on the left look very similar to what we saw with osimertinib, but these are some early data in patients with stage 1A disease who have completely resected lung cancer and then either go on 2 years of the TKI or observation, and you can already see the beginning of a disease-free survival difference here. And so this is very early data, but we're hoping to see more and also see this with other TKIs, such as osimertinib. But we really don't have it all figured out. This is some data from China for a first-generation EGFR inhibitor. They showed that 12 months of adjuvant TKI improved disease-free survival, but also a clear signal of overall survival benefit. And then they said, well, why don't we give people 6 months versus 12 months? These are these blue lines at the top, and they're really inseparable. And so again, even though we think everyone perhaps needs these drugs forever, probably we need to do a much better job of personalizing who needs any, who needs some, versus who needs none. And hopefully markers like plasma ctDNA and perhaps even radiomics will help us with this. So there's been a lot of interest in looking at what happens in vivo with preoperative therapy, and we've really been inspired by the changes with preoperative chemoimmunotherapy. This is a study of preoperative TKI, TKI plus chemotherapy, or chemotherapy alone. And I think what's really impressive is that preoperative chemotherapy alone in this oncogene-addicted population is not very good. Very little pathologic response, no complete responses, whether we use a TKI plus chemo, TKI alone, or chemotherapy alone. So this may be EGFR specific. But if we use everything up front, an association with event-free survival. And so, is this something we should be doing for all patients as a test? Can this help us understand who needs more or who needs less? And so we're still waiting to see how this fits into the treatment paradigm. The other thing that they've shown in this study is that using ctDNA, this is with an ultrasensitive assay, using whole genome sequencing, they use the Personalis assay here, we went from 20 or 30% with other assays or EGFR ddPCR in plasma before surgery to finding ctDNA in 71% of patients before surgery with this ultrasensitive assay. So, very helpful, and also maybe clearly defining a group that has a very good prognosis and perhaps might be considered for surgery alone. They also show that if we can clear ctDNA, this is a good prognostic factor and associates with major pathologic response, but still not pathologic complete response. And so I think that's very important as we move forward to next steps. So why aren't we curing more patients? Many of us believe that this is because between untreated disease and resistance, there is a state called persistence. So when you treat patients or you treat xenograft models, for example, you get resolution of the tumor, but if you look deeper, you actually find residual disease. This is very well differentiated, and if you stop drug, these tumors will repopulate. They are genomically the same as the original tumor, and they are still sensitive to TKIs. They do, however, have a number of other differences. They've got epigenetic changes. We've shown that with Ming Chow in our lab. Transcriptional changes, particularly through YAPTED, beta-catenin, and Wnt signaling, and more recently, data suggesting that TROP2 is important, which is, of course, very relevant for TROP2 targeting therapies, as well as other issues. And so now there are a whole host of studies trying to target patients in that minimal residual disease state, adding beta-catenin, YAPTED inhibitors, TROP2 inhibitors, very nice data looking at T-cell targeting therapies, as well as epigenetic changes. And so is this something that we should be looking at in even earlier stage disease and the screen-detected population? I'm just going to fly through this because I'm running out of time, but we've also shown that adjuvant therapy in ALK-driven tumors is important. This is a study where they compared the targeted therapy, alectinib, with chemotherapy, showing very nice disease-free survival data, perhaps a signal in overall survival, but time will tell. And a similar study, just like this, just as in the ADORA study, when you stop at 2 years, things start to change. So can we select who needs more versus who needs less? Despite being tablets, these drugs do have toxicities. Also a study where after chemotherapy, they looked at TKI benefit and again, nice disease-free survival benefit. A small proportion of patients with smaller tumors, so 3 centimeter and larger tumors with stage 1B, but we still don't have enough power to see what the impact is in this smaller group. Moving to the preoperative setting, just like in EGFR, what's interesting in ALK is we see very nice response rates, but we do see pathologic complete response. So are there differences here across the different genotypes and oncogene-addicted cancers, or is it just that some TKIs are so much more potent than others across the different disease states? And we saw some similar data presented by Leigh in a US study from Nautica, where again, very nice response rates, nice downstaging, suggesting that we could use this based on MDT discussion, and pathologic complete responses in about 25%, which we don't see in EGFR-driven cancers. A study that we'll be hearing about very soon, looking at RET fusion-driven cancers. This is about 2 to 4% of what we see. We also see it here in Poland. This was a study where patients could have chemotherapy. They got the TKI for up to 3 years or placebo. We have heard that there is an improvement in disease-free survival, and we'll see these data and how meaningful they are in clinic, hopefully soon. So duration is a challenge. Does everyone need chemo? What about radiation? We do have many local recurrences still. Neoadjuvant strategies, how do we position these? Do we really need the same level of evidence as we need in the chemoimmunotherapy space for pre-op versus post-op, or should we just do it, especially when we need cancer downstaging? And of course, how do we expand this across all of those 16 approaches to lung cancer that they talked about? And I just want to mention that I borrowed the slide from Masatsuboi, of course, who recently passed and really was extraordinary in his contributions to the area of early stage disease. A huge list of ongoing studies across different subgroups from stage 1A all the way to unresectable stage 3, pre-op, post-op, and consolidation as well. And I think for this group, I think it would be helpful to think about some of the platform studies. For example, in the LEADER study, they have a screening platform where they look for molecular testing, but perhaps what we should be thinking is not just molecular screening and a plug and play for the intervention where they can go on Nautica or different studies, but perhaps for your team, screening interventions, early screen detected lung cancers, and that same sort of idea of a plug and play where patients can then be put into different secondary prevention or even in primary reduction trials. So with that, targeted therapy is here in early stage disease, particularly in EGFR, ALK, and RET soon to come. Many challenges for what we still need to figure out. But I think for this group, how do we move these interventions and test them earlier? With that, I want to thank the organizers and hope you'll come to visit us in Toronto. I understand you're going to Vancouver instead, sadly, but it is very beautiful, and hopefully in a few years we'll welcome you to my hometown. Thank you.